afternoon, students. I hope you're safe wherever you are. With the cyclone, people who are in the path, please stay safe. That's of prime concern for us. Don't take a risk. If you miss this class, I am sure Rudrajit can, and we can organize something for you. Okay, but do stay safe, all of you. So we are going to discuss about a typical scenario. We are going to discuss this that, you know, um, day 3 post Whipples, this is a ward round. You're usually normally taken on a ward round and you're told that this patient has had a Whipple surgery and you're expected to answer a few questions. Now the examiner is going to ask you, what do you notice? Now for heaven's sake, that is a perfect trap. You know that we are going to discuss post-op pancreatic fistula or pancreatic drainage. We are going to, we are going to talk about pancreatic, fluid coming out, but you don't jump there. Just do what you would in a normal scenario. The first thing that you look after is the pulse rate. Then you look at the blood pressure. You look at the chart. You look at the temperature. You look at the respiratory rate. You see whether this patient is pale, and this is there are 10 things that you have to do before you reach the drain. So this is the first 5, followed by, if you start from the top, you look at the chest. Now, if you find that he has basal Krebs in both his lung bases, the commonest cause of basal Krebs, please, is basal atelectasis. You had a long Whipple surgery with retraction of the costal margin. So your first would be, if your examiner asks, what is the cause of the chest Krebs? You have to say that this is basal Krebs, basal atelectasis, and that's exactly what you would like to do. So from here, you talk of something called basal atelectasis, okay? Just remember that. After this, you look at the abdomen. Following this, you looked at the abdomen, and obviously 3 days down the line, you wouldn't be able to hear any peristaltic sounds. Now, the important thing to realize is post-surgery, the abdomen is going to be tight. It doesn't necessarily mean that it is peritonitis. The only reason, this is why you've gone through this entire gamut of pulse rate, blood pressure, temperature, respiratory rate, pallor. So you've gone through this first 5 to justify your diagnosis of a peritonitis, if you should want to say that. But at the moment, if your abdomen is reasonably firm, without any cardboard hard rigidity, you will have to say that, sir, I think the abdomen is in a typical post-op situation. It is going to be painful. Day 3 down the line, if you press too hard, it is going to be painful. I cannot feel hear the intestinal peristaltic sounds, which is natural, because Whipples, the mandatory thing is that you've done a vagotomy as well. So if you've done a vagotomy, there's very little chance that your bowel sounds, but you'd hear bowel sounds, though the small intestine does begin to work before that. So having looked at the abdomen and the intestinal peristaltic sounds, you look at the cough. Why the cough? Because you've had a prolonged surgery. This patient has been lying in bed for quite some time, and you're concerned about the possibility of a deep venous thrombosis. You look at the urine output, and I would expect you to know the amount of urine output that you should be expecting per hour. So you're going to be asked that. And you will find out whether there's a nasogastric tube or not. Because sometimes when you have a problem post-surgery, post-Whipples, you have delayed gastric emptying, and we'll address that later as well as a separate thing. And you can see that this patient actually has a long line putting. So we will look at the site of the long line as well, just to make sure there's no thrombophlebitis, there's no infection out there. Having done all that, so these are the 10 things that you've done. So you start off with the pulse rate again, you've seen the blood pressure, you've seen the temperature, you've seen the respiratory rate. For heaven's sake, if you are asked what I'm going to see, you must tell that. And now the examiner might tell you, okay, that's fine. Get on with it, because he doesn't have a lot of time. Then you will actually go through, I've done an examination of the general survey, he's slightly pale, I've done the chest, okay, what do you want to tell me about the drainage? So then you come to the 11th is the drain output. Now I'm going to give you two scenarios out here. So there is patient A who has a pulse of 88. Patient B has a pulse of 140, a blood pressure of 120/70 out here, and a blood pressure of 100/60, a respiratory rate of 28 in A and 32 in B, a temperature which is 99.4, borderline, but 103 in B. Pallor present in both. You've got basal creps in both. I mean, basal atelectasis is almost routine, and you have to aggressively treat that with chest physiotherapy. Can't find the intestinal peristaltic sounds. Urine output 50 ml per hour in A, 35 ml per hour in B. Drain is 240 in A and 500 in B. So the examiner turns around and asks you, what do you think? A, what is wrong? B, what is wrong? So I'm going to ask one of you to come in and comment. So among these two candidates out here, two patients, patient A and patient B, one has this parameter with a drain of 240, and patient B has this parameter with a drainage of 500. So what do you think? Anyone?
Good evening, sir.
Yeah, Komal,
Sir,
tell me.
Sir, there are two drains are there, sir. Right side drain and a left side drain.
Both
so
together.
Both together 500 ml.
Yeah.
So B, sir, B criteria is looking to be a patient is in a shock state, and we have to give fluid resuscitation.
So
and temperature is
that is fine. But if I ask you, do you think this is post-operative pancreatic fistula developing? Which do you think is developing a post-operative pancreatic fistula?
Sir, it depends upon the color of the drain.
No, it doesn't. I'll tell you. So I'm going to come to the next stage. What is the definition? What is the definition? The definition is just one and one only. That is a drain output of any measurable volume. It might be any measurable volume of fluid on or after post-op day 3 with an amylase content greater than 3 times the serum amylase activity. So the volume does not matter. It is criteria, the definition of a post-op pancreatic fistula or pancreatic leak is a drain output of any measurable volume of fluid on or after post-operative day 3. Why not before? Because don't forget, you've cut the pancreas and the pancreatic fluid could have leaked out into the abdomen. So the first 2 days you don't do the amylase because you wait for the amylase-rich fluid to drain out. It's only after day 3 that if you have an amylase content greater than 3 times the serum amylase activity, you will call this a pancreatic leak. And this was an update. This is a 2016 update. And you will always quote this. The quotation is, and it's an international study group on pancreatic drainage, pancreatic fistula, on both the grading of pancreatic fistula. So, and there were a number of people out here. So you will say that this is the international study group on pancreatic surgery. And the people out there were names like Falcone, names like Goma, names like Neoptolemus from UK, and from Tata Hospital, Shrikhande, Sele Shrikhande. And finally, the person who's supposed to be the father of it all is Martin Buchler. So you will quote this, and I will actually give you reference to this paper when we finish. So now we are going to come across a situation. You have the drain amylase. It's less than 3 times serum amylase. And you assess there's someone with a fever, the other no. So if you don't have fever and this patient has a drainage of, let's say, 240 or 500, or let's say 240, let's take this man, patient A. So he doesn't have fever. Now what are you going to think? So now, Komal, you said you're going to look at the drain.
Sir,
Now is the time.
Sir.
Yeah.
Sir, as the patient don't have any fever, so we have already ruled out the early sepsis or the SIRS condition. Now we will be looking at the color of the drain, and like dark colored, if it will be, it most probably suggestive of a pancreatic leak, or if it is a greenish or a golden yellow
No,
color, then
hang on. If the drain amylase is less than 3, it is not, again, I'm going to repeat, it is not a pancreatic leak. Okay. If it is less than 3, it is not if it is less than 3 times serum amylase, it is not a pancreatic leak. It is some other thing. So what are the other things? And you're quite right. You're absolutely right when you said you're going to look at the color. It could be plain, almost like ascitic fluid. If it was ascitic fluid, like what blood test might tell you that this is the reason? You said, oh, this is the reason. If your serum albumin, let's say, is 2.5 or below, this is hypoproteinemia, isn't it? It could be blood. So you obviously have to think of some other course of bleeding that might be causing this increased drainage. Or it could be white. So it could be chyle. So these are the things. Quality of the drain. You have hyperproteinemia, you may have bleeding, you may have chylous drainage. And we'll address all of that later. But let's take a situation where there's fever and sepsis. So now what do you think? You look at the drainage tube, it could be turbid or it could have bile. So what do you think if you have a drainage with, patient B, let's say, who seems slightly compromised? He is heading towards some sort of a major problem. His pulse rate is 114. His blood pressure is hovering around his minimum. His mean arterial pressure is around 40. His respiration rate is high. He's got temperature. He's got pallor. And his drain is 500 ml per hour. Urine output, this was wrong. He has a urine output is around 35 ml per hour. So what are you going to think? If it's turbid, you might think of an infective collection. Sometimes you do an operation of a Whipple's on a patient who's had a stent put in, and you have peritoneal fluid out there. Whenever you have a stent, and I'm glad Komal answered, because Komal's thesis under me was on this, that we found a huge number of people, about 50% plus of people who've had stents put in, had infected bile, and bile which was responsive only to cholesterol and tigecycline and not to the usual antibiotics. So you have either an infected collection, you know, peritoneal fluid that has become infected, or you might have bile stain. Now, the problem with bile stain is, if you should have a bile stain for a pancreatic or duodenectomy, it has to have been an anastomotic leak. So why do you think, why did I say this? Why did I say that, it is an anastomotic leak? If you think of the quality, hang on, I need to get to the next. So if you should have that, you have to carry out resuscitation. And Dr. Ramanuj Mukherjee was telling you about this. He was telling you about the sepsis bundle, surviving sepsis campaign bundle. And I would strongly recommend that you read this up if you're before you go in for your examination, and I'll mention it in passing. So you do a resuscitation, you look after the nutrition, and you have to do a source control. But the reason you have an anastomotic leak is this. Think of a Whipple surgery. Let's take this color. Okay. So hang on. So I'm going to draw this. Okay, so that is the liver, right? And let's take another color. We'll take another color, which is green. Now for green, we had the bile duct heading down out here, which has been cut. You have, if I choose another color like that, you have the pancreas, which has been cut. And there you have the pancreas. And on top of all that, you have, if I can choose, let's say this color, you have the stomach, which has been cut out here. So think about it. I've got a portion of jejunum up, and that portion of jejunum has come on this way, all the way out here. So we've done one anastomosis there. That's the pancreatic jejunostomy. That's the choledojejunostomy. And we also end up doing a gastrojejunostomy there. Okay. So think about it. Now we have a bilious leak. Now, which are the sites that you might have a bilious leak? You either have a bilious leak, we'll start off with the commonest out here, which means it's not just bile, it is also enteric, because that part comes from the jejunum. If you might have a leak, a biliary leak from there, again, it's bilioenteric. Let's suppose you have a leak from there. That is also bilioenteric. And finally, if you've done a feeding jejunostomy, sometimes the leak is beside that. So again, a bilioenteric leak. Okay. So there we are. So if you have, that is why I said, if you go back to that, if you have either an infected collection, but if it is bile stained after a pancreatic or duodenectomy, it is almost all certain that it has to be a bilioenteric or an anastomotic leak. So therefore, resuscitation, nutrition, and definitely source control. Now we come to another stage. We now have a drain amylase, which is more than 3. Now, it doesn't matter if that's 240. It doesn't matter whether it's 500. If you have a drain amylase, which is 3 times the serum amylase, and both of these have to be taken at the same time, it is a pancreatic leak. No question about it. It is a pancreatic leak. So my question is, this is the gradation of a pancreatic leak. You can have a biochemical leak, which is grade A, or you can have a grade B or a grade C. So the event is, how do you differentiate between them? If it lasts for longer than 3 weeks, they all last for longer than 3 weeks. Is there a clinical relevant change in the treatment of the post-op pancreatic fistula? For a grade A or a biochemical leak, no. For a grade B, yes, because you need to consider drainage, and definitely for a grade C, where you need to sometimes consider intervention. So is there a chance of a drainage of a collection, either percutaneous or endoscopic? In a biochemical grade A leak, no. You could need it in a grade B or a grade C. Angiographic procedures for a post-op pancreatic fistula, particularly to assess and to consider for stopping bleeding. In a biochemical grade A, no. You might need it in a grade B. You definitely might need it in a grade C. Reoperation for a POPF, no in a biochemical leak, no in a grade B, where you've managed it with either drainage of a collection or an angiographic procedure, but yes for a grade C. Infection, With a post-op pancreatic fistula, no. In a grade B, you might have infection, but there's no organ failure. In a grade C, yes, you have an infection, and this time you have organ failure. So that is the most important distinction between a grade B POPF and a grade C POPF. So, I think you need to mute your mics, please, chaps. POPF related organ failure, no in a biochemical leak, no in a grade B leak, yes in a grade C leak, and a POPF related death, very unusual for a biochemical and a grade B leak, definitely for a grade C. Now, I'm going to finish up by, when I finish up, I'm going to give you some reference to this slide. So, is it possible to predict which patient would have a pancreatic fistula? Yes, it depends on the type of resection. If you've done a pancreatic duodenectomy, the rate is 13%. For a distal pancreatectomy, it is far more. It is often 30%. And if you've done a central resection, sometimes you have a endocrine tumor or a neuroendocrine tumor of the central part, and you remove the central part. You don't want to do a total pancreatectomy. The reason is that you don't want to leave this patient with a brittle diabetes. There you have two anastomotic sites, one towards the head, one the other way, and that has one of the highest incidence of post-op pancreatic fistula at 40%. So just remember these figures. 13 for a pancreatic duodenectomy, 13%. Distal pancreatectomy has a rate of 30%. I've evened it out. It's actually 29, but it's far easier. I find it far easier to remember in an examination. 13, 30, 40. Histology, is that important? Yes, it is. Because if you were operating on a patient who has a pancreatic ductal adenocarcinoma, or a patient who has chronic pancreatitis, the gland is firm, and you have less chances of a post-op pancreatic fistula. If you have all the others, then it actually, I'll come to the next slide where it shows you all other tumors like a duodenal or a periampullary have a higher incidence of post-op pancreatic fistula. Pre-op imaging studies. Now, guys, I want you to keep this up your arm. Again, this is the examination technique. And I'm talking of something that is fairly recent. So pre-op imaging studies to identify a firmer gland, and it can be MRI, like here. This paper came out in 2016 in the radiology journal. And what they actually did is unenhanced T1 weighted images show a pancreatic to muscle intensity ratio of this one shows a ratio of 1.16. Any ratio of less than 1.4 means that you have less chances of a pancreatic leak because that gland is firmer. The moment it goes beyond 1.4, going up to 1.5, 1.6, then you have a problem on your hand. Now, the similar assessment has been made on a CT scan, and I'm going to take you through this patient. This man was sorry, I beg your pardon, was not, definitely not was. He is a pediatrician, and he is actually, his clinic is right in the middle of the cyclone that is coming up, very close to the coast. Now, this man was a heavy smoker, a pediatrician who was heavy smoker. He saw about more than 150 patients a day, and he developed 2 nodules in the lung. He was very scared, went for a PET scan, chest X-ray was fine. Now, what did he pick up? He picked up a hot spot in his duodenum. But in addition, the PET scan picked up this. PET scan picked up this. This was a renal cell carcinoma. Okay, so now this is the gentleman who has 2 pathologies. So I'm going to show you what is the problem. Now he had a very early, obviously it was picked up by chance. He wasn't jaundiced. Now, if I were to show you his CT scan, now I'm going to show you the CT scan. Now I'm going to show you something. This shows that that's the kidney. So it's not an early stage. It's an early phase. It's reasonably delayed. And now you can see that you can actually, in the pancreatic protocol, you can actually see the pancreas quite clearly. Can you see that pancreas? That's the pancreas. That becomes clearer later in people who have fibrosis. Now, the funny thing is, this man had an ampullary. You can see that he had an ampullary carcinoma. And you can't see the pancreatic duct. So he has a narrow pancreatic duct. Not only that, what surgery is going to have and what surgery we did, this was 2012, that's 8 years down the line, he had a right radical nephrectomy with a Whipple's operation. So quite a challenging operation. But, you know, he, despite having a firm pancreas, the offset was he didn't have a dilated pancreatic duct. And in addition, he had an ampullary carcinoma, so that it wasn't a pancreatic ductal carcinoma. Therefore, the risk factors, per operative risk factors was thus, you know, gland, this is the scoring system that has been evolved. So if you have a gland texture which is firm, the points are 0. You have a soft gland that's 2. If the pathology is pancreatic ductal adenocarcinoma or an associated chronic pancreatitis, your scoring point is 0. If you have an ampullary, duodenal, cystic, or an islet cell tumor, your point scoring system is 1. Now look at the pancreatic duct diameter. More than 5 millimeter, 0. 4 millimeter, 1. 3 millimeter, 2. 2 millimeter, 3. Less than 1 millimeter, 4. Intraoperative blood loss, less than 400, 0. 401 to 700, 1. 700 to 1000 is 2, more than 1000, 3. Now, this gentleman had about less than 400 ml of blood loss, but he had a duct diameter which was less than 1 millimeter. He wasn't jaundiced, and he had an ampullary. So that gives him a score of 4 plus 1, 5. And sure enough, after surgery, he had a bit of a problem. He had a biochemical leak which needed correction. Now, this is the fistula risk scoring point out of 0, out of 10. 0 is negligible. There's hardly any percentage of pancreatic fistula forming. If your range is 1 to 2, you have a 6.6% chance of developing a pancreatic fistula. 3 to 6. So this gentleman, the doctor had 4 plus 1, 5. So he had a moderate risk, 12.9%. So that's about 13% chance of developing a pancreatic fistula. 7 to 10, you have a very high risk, which is around 28%. So this is something that you have to keep in mind. That risk scoring is something that please keep in mind. That has been accepted after 2016. That has been accepted. So what you assess it is on, you don't need to remember all that. Gland structure, pathology, pancreatic duct diameter, and intraoperative blood loss. 4 things. Please remember that. So if you remember that and you remember that they get scored, you tell your examiner, sir, I'm not very sure about the exact numbers of the scoring, but that is the fistula risk scoring. It depends on the gland texture. It depends on the pathology. It depends on the diameter, and it depends on the entire blood loss. We, these great people, great pancreatic surgeons all got together and they said, this was my scoring system. We don't need anything else. Right. So how do you manage present management? Nutrition. Now, surprisingly, a lot of pancreatic cancers now go in for neoadjuvant chemotherapy and radiotherapy, plus minus radiotherapy. Now, it's all the papers that are coming out after NAC for pancreatic cancer have started. All of them say that the treatment makes the glands more fibrotic. Gemcitabine, makes the gland more fibrotic, as does radiation. And surprise, surprise, they actually do remarkably better in as much in terms of pancreatic fistula formation than people who haven't had neoadjuvant chemotherapy. So nutrition, neoadjuvant chemotherapy, pharmacotherapy, somatostatin analog. If your examiner asks you, you will say, sir, I've seen this being used, but if you look at the randomized controlled trials, no randomized controlled trials justify this. It's something, if I can give you an analogy, it's like bowel preparation for colonic surgery. You know, you will see your consultants doing that, and at conferences go and say, oh, we don't believe in it. So this is it. You know, most pancreatic surgeons would use somatostatin analog as a preventer, but you know, it doesn't stand the test in randomized controlled trials, which is why I've put in this question mark. Goal-directed IV fluids, if you overhydrate, and that has been the one of the major criticisms of this Surviving Sepsis campaign, and I'll do that. So if you overhydrate the patient, it becomes more edematous, and these are the people who would actually then land up with a pancreatic fissure. The type of anastomosis, you will quote this study called the RICO-PANC. RICO-PANC comes from reconstruction of the pancreas study. So RICO-PANC study of 2012. It doesn't matter whether you've done a pancreatical jejunostomy, either mucosa to mucosa, or you've done a dunking, that invagination technique, or pancreatic or gastrostomy. They all have the same incidence of pancreatic fistula formations. Stents, glues, and drains don't seem to work. People have used them, have sworn by them, but they haven't stood the test of the randomized controlled trials. So, what are the types of anastomosis that you know about? The anastomosis can be, let me just take a, so in one, that is the pancreas, that is the duct, and you bring up the intestine and you bring up the jejunum out here. Pick up the jejunum out here, and you've done a mucosa to mucosa anastomosis, right? So this is one. The second type is pancreas again out here, with the duct out here. And what you've done is a pancreatic or jejunostomy, but this time what you've done is hang on, let me just, wipe that off. I'm going to choose another color, and I'm going to use, let's say, yellow. Okay. So in this situation, what you've done is you've brought the jejunum over completely out here. This is the usual name for this is called dunking. So you do a serosal anastomosis out here in the anterior. On the posterior, you don't have a lot of chance of doing a serosal stitching, because pancreas is basically a retroperitoneal structure. It has peritoneum only on one surface, and that is the anterior surface. That is covered by peritoneum. You don't have peritoneum posteriorly. So out here, it's a serosal, but you have the entire, this is called the dunking. It's called the dunking procedure. So you better know that this is dunking. Right. Now, the other option is that we have to draw this out first. That's the stomach. And you've cut it out here. And what you do is, if I take that color, you bring the pancreas out here and do an anastomosis to the posterior wall of the stomach. So that's a pancreatic or gastrostomy. Some people swear by this, but believe me, there's no difference. The only thing that happens is if that should leak, that's directly in the path of food. So you have to make other arrangements. You either have to get a tube down, Ryle's tube, or a feeding tube into the gastrojejunostomy, or you've got to make a separate feeding jejunostomy into the jejunum. So if I draw that, you bring that into the afferent loop of the jejunum that's going down, right? So you circumvent that, because if you have a leak out here that is actually in the passage of normal food, you can't give this patient food. So either that, or you've got to make sure that you've got a feeding jejunostomy somewhere out here, distal to it. Okay, right. So none of them have any difference whatsoever. The difference between them is zero. That's been validated by a number of studies. Okay, right. So with a biochemical fissure, how do you treat these patients? Monitor. When you monitor for sepsis and for collection, you ensure that there is a good nutrition, and nutrition for this patient is better done enterally, because your small intestine works. Sometimes you have, even with a biochemical fistula, you have a delayed gastric emptying. So it's vital for you to actually have a feeding jejunostomy, either a feeding jejunostomy or a nasojejunal tube down. My preference is for a nasojejunal tube, but a lot of people swear by a feeding jejunostomy. That's absolutely fine. The use of somatostatin analogs, it's been used after treatment for a biochemical fistula, but it's, people go ahead and use it. It's one of those things, people use it all the time, but they say, oh, it hasn't stood the test of time, except that FDA is right now in the process of accepting one of the newer octreotides, some of the new somatostatin analog, and that seems to have done a wonderful job. But you have to take everything with a pinch of salt. It's just on initial trials that it's been validated. Sometimes you start using that, then over a period of time, over a randomized controlled trial, you find that it doesn't really stand up to the scrutiny of a randomized controlled trial. It might be a pharmacological push. Now, for B and C grade fistulas, supportive care and source control. For source control, drainage of any collection, you need a CECT of the abdomen. All collections have to be drained. Best is to go in for interventional radiology and draining. You might have to go in for an angiographic intervention, particularly if you have a pseudoaneurysm which is formed after that, which is quite common and it tends to bleed. Or you need to go in for an emergency laparotomy. Now, this is the surviving sepsis bundle. And for people who've done a bit of reading, it used to be 1 hour. Now, that was the initial controversy. The reason is, why now it's for the first 3 hours is, in the first 3 hours, you measure serum lactate and recheck if it's more than 2 millimoles per liter. You immediately send off blood cultures from 2 different sites. And having done that, you start off broad spectrum IV antibiotics. Now you give IV crystalloids, preferably ringer lactate, not normal saline. And when we are doing fluid and electrolytes, we'll tell you why. 30 ml per kilogram over 3 hours. Now, if you're going to give it over 3 hours, you can't have a first 1 hour assessment. So at the end of that was the first controversy about that 1 hour bundle. That you're saying that you give crystalloids over 3 hours, then why should it be a 1 hour bundle? So now they've revalidated it to the first 3 hours. Even then there's a lot of controversy, but as of right now, that surviving sepsis bundle, for the first 3 hours, you measure serum lactate, recheck if more than 2 millimoles per liter, blood cultures do different sites, broad spectrum IV antibiotics, IV crystalloids 30 ml per hour over 30 ml per kilogram over 3 hours for hypertension, or if your lactate is more than 4 millimoles. Vasopressors if hypertensive, even after fluid particularly if the mean arterial pressure is more than the 65 millimeter mercury. If now coming to hemorrhage, this series of pictures has been provided by Dr. Avik Bhattacharya, who is one of our interventional radiologists, and he used to work at Tata Center, Bellevue, and Calcutta Medical Research. People who work there know this. Now, this was a triphasic CT scan that was done in a patient who had blood in the drain and some amount of blood in his nasogastric aspirate. So if I now take you through this, and I'm going to let's take this color blue. See, if you take this color blue, you realize that that is actually, no, hang on, I need it a bit. That is actually the portal vein. And that is the superior mesenteric vein. This is post Whipple's. And this is actually the main hepatic artery that's dividing into right, and the left doesn't show out here. But problem was, you know what? Nobody understood what this was. Can you see that? And in addition, if I now rub off all of that, you will also notice that, let me choose another color, let me choose gray. And there's some amount of grayish stuff out here around that. These are actually clots. Okay. So what he had was essentially a bleed. This was actually a pseudoaneurysm. And he underwent this, an angiography. And on an angiography, you now see that that is the pseudoaneurysm. Can you see that pseudoaneurysm? And that's the tip of the catheter. This was embolized, and now you can see that that is actually the left gastrociliary. And
Sir, voice not audible, sir.
Okay.
let me know.
Hello?
Hello, Rudra.
No, I can hear you now.
Yes, sir.
Okay.
I think
You
you
need
went
to
off
give
for
me-
a minute.
Okay. So
Yeah.
where did I go off?
I think you were showing that extra thing after, what is that? The CT scan.
Okay.
Sir, again the aneurysm part, sir.
Okay. So we were here, isn't
Yes, sir,
it?
from here.
Yeah,
From here.
Okay. You can all hear me now?
Yes, sir.
Yes,
Now
sir.
clear.
Yes, sir.
Okay. Okay. Sorry about that. Now, see, that is the hepatic artery. Okay. You can see the right hepatic branch. I'm going to color this. That is the portal vein. Okay. And you have the superior mesenteric out here. It doesn't show well, but superior mesenteric and splenic forming the lower part of the vein. The problem was we couldn't decide, this is a patient who presented with low blood pressure, tachycardia, pallor, dropped his hemoglobin, and he had blood in his drain. He also had some amount of blood in his right tube. Now, we had a bit of a problem, but if you look out here, you notice that we had no explanation for this. Okay, we had no explanation for this. In addition, if now I wipe all that off, you will notice that he actually had a bit of clots all around the hepatic artery out here. So what we requested Dr. Abhik Bhattacharya to help us out. And what he did was he put in a catheter angiogram. He did carried out an angiogram. And now you can see on the basis of the angiogram that there's a pseudoaneurysm. Can you see the pseudoaneurysm? Can you hear me now?
Yes,
Hello?
sir.
Yes, sir. Yes.
So this was a pseudoaneurysm. And what Dr. Abhik Bhattacharya did was he did that. He put in a catheter and he embolized it. Now that is the celiac axis. That is the left gastric. That is the splenic artery. Can you see the hepatic? You can't see the hepatic artery at all. He coiled the entire hepatic artery and we were very worried. We said, Avik, you've coiled the entire hepatic artery. What will happen to the liver? The liver needed a bit of support, but believe you me, it recovered completely and this patient didn't need any other problem. It is then that you realize that about 70 to 75% of blood supply to the liver goes by the portal vein. It's that 30% to 25% that is supplied by the hepatic artery. And if you have coiled the hepatic artery, the two things that you have to ensure is that you must make sure that you cover the patient with antibiotics. You must make sure that the patient is hydrated well. You must make sure that the patient gets plenty of glucose to build up the liver glycogen stores. And the other thing is you must start enteral feeding, because you know what the infection, the bacteria reach the liver through the portal vein. And if you have a patient who's fasting, the intestine is completely inoperable. That causes a bigger chance of infection, right? So for a biochemical fistula, you monitor sepsis and collection, nutrition and somatostatin analog. Hang on, we go back. As I said, for a B and C grade fistula, we've been through supportive care and I've shown you that bundle and of course source control. If there's collection, infected collection, you go in for drainage, either interventional radiology. I've shown you an angiographic intervention where there was a pseudoaneurysm and that was embolized and the patient recovered and went back home. You might also need to do an emergency laparotomy for patients who've had leaks. Now, here is where there's a bit of controversy. Some people say if you have a full-blown pancreatic or jejunal leak, you do a pancreatic or gastrostomy and get away with it. It's a bit difficult. There are people who would actually complete this by doing a complete pancreatectomy, but then you expose the patient to a frightening chance of a brittle diabetes. So you have to remember that in India, most people, most of us who do pancreatic surgery shy away from doing a total pancreatectomy because brittle diabetes is far easier controlled by countries which have a better healthcare system than ours, but it's a frightening thing to expose a patient to without, to go through life without an entire pancreas. Now, the issue is you have to remember that there are a lot of controversy about the staging. So you have a calorie staging, you have a Roberts staging, you have a Munn group staging, and this was a Korean study which said that this was more appropriate for India, for Korea. But the important thing to realize is that if you look at that study, if you look at this particular paper, which was the 216 update of International Study Group of International Study Group of Pancreatic Surgery, and you look at the number of people who've been taken in all over the world, and that actually represents people from all over the world. This was 2017 March. I think most people would accept that this was the paper to refer to if you're looking at pancreatic fistula prediction and gradation. Now, this is a paper that if you are interested, people who are interested can actually read this paper. I mean, this gives you everything. So if you read this paper, it's in the Dove Press, that's a Dove Press, Post-Hoc Pancreatic Fistula Review of Traditional and Emerging Concepts. This came from Sydney. Nam, Connor, Samra, and Mittal. So these were the people who did an excellent, and actually if you go through this particular thing, you don't need to read anything else at all. This is a wonderful single paper which gives you the whole gamut of pancreatic fissure. If you're interested, go through, people who are interested, go through this paper. This is something that is highly, highly, highly commended. Now, except for one thing, Nam, Connor, Samra, and Mittal have their own hypothesis. Now, if you're reading this paper, I wouldn't have shown it to you. But if you read this paper, you will see the hypothesis. Please, please do not end up in an examination saying that this is the hypothesis. So this is just a hypothesis. You have to remember that. So this is just a hypothesis. And the hypothesis is this. This is adapted from there. That what they've done is they've done something called the Asena duct density. They call it the Asena score. So if you have an Asena score, and if you've damaged the cells during surgery, either by causing ischemia or overhandling or a soft gland which you've stitched quite a bit, you have a lower activation of pancreatic enzymes and a higher volume of damaged Asena cells during resection. So you actually have something called a post-operative pancreatitis. Now, this is very nice for people who have a fistula. They can always blame it on pancreatitis rather than their surgical technique. So just be careful that you don't do that, because this is something which is absolutely new. This is Nam's hypothesis, Nam and Mittal's hypothesis. You don't do that. So what they say, if this is post-op pancreatitis, they actually do an immediate assessment of the fluid that is coming out, whether it's high in amylase, and they do something called an immediate and continued week of amylase-rich pancreatic fluid, so intraoperative amylase content and drainage of amylase-rich fluid. And because of this pancreatitis, this causes disruption of the anastomosis or the staple line if you've done a distal pancreatectomy, and then you have a post-operative pancreatic fistula. Again, there's only one thing that you need to remember. This is only a hypothesis. Please do not quote this unless asked for. And the reason I'm giving you that is I would recommend that you go in and read this article. They do have this hypothesis, but please don't come out with that first. Okay, so open for any questions. Rudrajit?
Yes, sir. Yeah. Yes, sir.
I thought I'd finish early because of,
Okay. Does anyone have any questions?
So drain should be put ideally where, sir? Whenever you use to drain in the abdominal part after doing Whipple surgery, sir.
Well, what I would suggest, then I'll go in for the sharing again, and what I'll do is, hang on. Let me get that. Yeah. So if you've done the surgery, our usual technique is that what we do is, see, the one that drains, that leaks the most, at least in our hands, I don't know about other people, the one that leaks the most for us is the pancreatico-jejunal anastomosis. Okay. We do a lot at CMRI, and the people who are there from CMRI will tell you that they might have not have seen head and neck surgery, but they've seen plenty of. So you've got the jejunum out here. Okay. That's the jejunum out here going through. The gastrojejunostomy very, very, very rarely leaks. So that's the stomach, and you join this bit out here to the gastrojejunostomy. What you also have is an anastomosis out here to the bile duct. Okay, so what we normally do is we would actually put in a drain across out here. Now there's an issue. Some people say don't put in a drain. If you put in a drain, it causes more leaks. So we don't subscribe to that. We are people who have had pancreatic leaks. I wish I was in a situation where I could have told you that I have done so many surgeries without a leak. I haven't. You also put in a drain out here. Hang on, let me sorry, get that out. You also put in a drain behind out here. Okay. So that is our principle of putting in a drain. The two areas that might leak for us are number one for us is the pancreas. What is this? Number one for us is the pancreatic jejinostomy, and number two is the cholecystectomy. So we are worried about these two. So these are the two drains we normally put in. This usually lies behind the stomach. The other thing we normally do is, and always we recommend it to all our youngsters, is, you see, that is the celiac. I'm just going to wipe that out. So we're going to, so that is the celiac. The moment it comes out, it gives off the left gastric out here. It gives off the splenic. That's a wavy thing that goes behind the stomach all the way to the spleen. Okay. But you also have the common hepatic, which goes in out here. And the one that you cut is the gastroduodenal. You cut two vessels out here, one the right gastric and the gastroduodenal. And we find that a large number of our leaks are actually from the stump of the gastroduodenal, which is why our present principle is to do it twice. We tie it and we also transfix it. So that's two ties. And sometimes what we also do is, if you have a bit of the falciform, you remember that we've already mobilized the falciform. So if you, the falciform we put out here as a sort of a cover. We push the falciform in. We have rather, you've seen that that picture that we showed you. That was a bleed from the gastroduodenum. Okay. So does that answer your question?
Yes, sir. Thank you, sir. Can you please repeat that you were saying about that bilioenteric leak, sir, regarding anastomotic leak? Can you please repeat, sir?
If after a pancreatic or duodenectomy, you have bile coming in the drain, it has to be a bilioenteric leak. Why? I'll show you on this one itself. See out here. Let me take this bright red. So where will it leak? It would either leak from here, okay? And if it leaks from here, it's pancreas P out here and jejunum J out here. So it's a pancreatic or jejinostomy. So it's a combination of bile coming from there and pancreatic juice, right? So which is why it's bilioenteric. If you have a leak from here, it's obviously that bile coming out here. So this is one anastomosis which might leak. You have two anastomosis which might leak out here. So cholecystectomy, which means the leak is never going to be from one side, isn't it? Get
Yes,
it?
sir. Yes, sir.
It's not just that. It is also the enteric juice coming out. It's not just the pancreatic juice coming out. It's also the enteric juice coming out. So bilioenteric. And obviously, if you, number three, you have a drain from here. If that is the one that is leaking from the gastrojejinostomy, it will always be bile from there, and bile and enteral contents from there. So that is the third. So 1, 2, 3. So post pancreatectomy, if you have a pancreaduodenectomy, if you have a leak, it has to be a bilioenteric. If there's bile, it will contain intestinal fluid. If, however, and surprisingly, we find that the leak rate after a distal pancreatectomy, you've done a pancreatectomy and you've done a distal pancreatectomy out here, you know, that is the thing. That leaks more. That's about 30%. This is about 13%. That's 30% leak, which is why what we started doing is, and we do it laparoscopically nowadays, we actually, though we take a staple and you put in a staple out here, we've done quite a few now. You actually take a bite out here, take a proline and take a bite throughout here. You know, people say that that's sensible because you can then identify and take a bite out here, okay, with proline.
Thank you, sir.
Remember that this leak is 13%, this leak is 30%, and if we remove all that drawing, see, sometimes what you do is you land up with something like this. You have, that's the stomach, and you have the pancreas out there, that's the pancreas, and you actually had a tumor out here. So you've removed that part, the central part, and you've taken it off the superior mesenteric, exposing the aorta from here. So what you then do is, for people who are interested, you can read Schwartz. They had something called a Jones-Shire's double jejnostomy. So what they do is they bring it out here, and you have an anastomosis out here and an anastomosis out here. Can you imagine, to the jejunum? So you have now a problem of leak from here or a leak from here, and this rate is as high as 40%. Okay.
Thank you, sir.
Okay, sir. Hello.
Yeah, tell me.
Can I show some slides, sir?
Yeah, sure, please. You have some
of entire ward clinics.
Yeah, okay. So I'm going to stop sharing, okay?
I'll just take 20 minutes, sir.
Yeah, sure.
I'll just give them a recap of what is happening.
I mean, the way the winds are getting up, I thought I'd try and finish as early as possible.
I know. I'll just tell them a quick recap of what needs to be done. Okay, sir has shown you the entire thing, everything that is there in a pancreatic fistula. What I am going to do is that I am going to just show you the type of questions they're going to ask you. Okay, so I'm not going to the ISJP of classification which sir has said. Okay, so you've come and they've asked you, you've got this drain that is coming, and they'll ask you that how will you basically suspect that it's a pancreatic? How will you know that something is going wrong with your patient? See, the first, can everyone answer me? Hear me?
Yes, sir.
Okay, so they'll ask you, how will you know
Yes, sir.
something is wrong? Okay, so you please say the first recognized indication of a major disruption of pancreatic anastomosis is actually deteriorating clinical indices such as tachycardia, hypotension, fever, or oliguria. Okay, don't jump into question number 8 or 9. Answer like this, sir. If the patient has tachycardia, hypotension, fever, or oliguria, I think I'll have a problem. Okay. Now, delayed return of bowel function or delayed gastric emptying is also common, but these are very non-specific findings. Then you do a leukocytosis, or there will be a leukopenia in severe sepsis. Electrolyte abnormalities, you encounter acidemia, hypokalemia. There can be thrombocytopenia, thrombocytosis, then moving towards SIRS. Okay, coagulopathy and anemia are frequent laboratory findings. So then they'll ask you, how will you know that something is very wrong? You have to take an operation, will you have to take the patient back to re-laparotomy or not? You have to say, yes, typically in grade C fistula, which Sir has said, that grade C, normally sometimes you have to take him back to operation. But remember, majority of the A and B, you can treat conservatively. So in certain terms of grade C fistula, when surge is coming, then you will have to think of whether to go back to an operation or not. Okay? So remember, majority part of the fistula that is there, if you are suspecting it, it can be treated conservatively. So for example, type A, type B fistula, The two primary clinical goals over here is the early settling of a massive pancreatic anastomotic failure, are goal-directed resuscitation and maintaining end organ perfusion, and establishment of controlled pancreatic fistula. So your answer should be, sir, in type A and type B fistula, I'm going to do goal-directed resuscitation and maintain end organ perfusion and establishment of a controlled pancreatic fistula. You give IV fluids, you correct acidosis, you do more vascular access, central venous catheter. See, these are the things that the examiner will want to know. They will not want to know that whether you're directing PJ to pancreatic or gastrostomy or not. Okay, so use these terms which are there in yellow: goal-directed resuscitation, establishment of controlled pancreatic fistula by IV fluids, acidosis, and we'll do central venous catheterization. So they'll ask, what is your investigation? Now see, for CT, you don't do a CT scan to see a pancreatic disruption. You basically are doing a CT scan to see a sepsis, any collection of fluid is there, which can lead to your infection and sepsis. Okay. And also in these patients are basically too ill to, they'll tell, the examiner will say, this patient is literally having surge, how will you take him to the radiology? Okay, so then you say, sir, I just have to see whether the whatever collection is there, I have to drain that collection percutaneously and the patient will settle. Okay. Also in SIRS, the renal parameter, the renal function is already depressed. You don't want to give a contrast and make the patient worse. There have been people, you know, surgeons, especially new surgeons who have done the pancreatic, it has leaked. And by, you know, inexperience, they took the patient and did a full enhanced contrast in a CT scan and the patient passed away. Okay, so you will have to be careful. See, examiner, we're going to ask you these questions, and if you can answer, see, the patient is too ill to transport, or the contrast can cause some sort of renal failure. These are basically honors answers in your level. Okay, so remember this. So there's a CT scan. We can see axial view. The A is the pancreas over there. B is the collection that is there, fluid collection, and C is the small stent that they have given. Okay, intraoperatively. So the examiner is going to ask you, so what will you do next? Now, if there's some people who do not put drains, very fresh, in our CMRI, we always put drains. But if there's no drain and the patient is very sick, you just put, you tell the radiologist to just come do a USG and put, if you can see collection, put drains and come out. It can be multiple, one drain, two drain, but just put and relieve the collection. If the patient has drains, your main concern is that if the drain has shifted or not. So you can do a non-contrast CT and then you basically either put in new drains or your old drains you cannot maneuver. Don't try to do that. Put in new drains and come out. Okay. So next, what are you going to do? As some of you have answered, you'll see the color and everything. I think sir has told you about the bilious and from where it is coming, about gastroenteric. I'm not going to go that. So bloody drainage also sir has told you. Remember that the aneurysm does not happen immediately. Aneurysm normally happens 2 to 3 days after the pancreatic PJ leak. Okay, so you have to be very careful. So what we do is that we give broad spectrum antibiotics. Okay, and always remember it is a good practice to take a bile culture from the CBD before during the operation, because that is going to give you the microflora that is there, and according to that you give the antibiotics. Sir, and we know that, you know, there's a lot of, you know, resistant organisms are there. So it is better that if you know from beforehand, you give it at the one go. You cannot keep on changing because the patient will not give you time. Okay. So if you can say that, sir, sometimes it's a good practice to take bile culture during our indexed operation so that we know if it's a leak, you know what to do. Regarding the reoperation, I don't think sir has touched it exactly when we do a relaboratory in type C. Now, see, the decision to reoperate is based on the presence of refractory and progressively worsening SIRS in the presence of apparently adequate drainage. Be careful of this line. If the SIRS is progressing and you know that the patient is draining well, that means something else is happening. So we need to go take him back to relaboratory. Okay? It should be stressed that reoperation for major pancreatic anastomotic disruptions is and should be an extremely rare event. As sir has said, majority of these patients in type A and type B and some type C becomes okay with conservative management. Now, an overwhelmingly majority of these situations can be managed with non-operative percutaneous drainage and aggressive critical care. So your critical care consultant becomes a new friend, and your critical care RMO becomes a good friend. Give him as much chocolates as possible, or take him out. He has to monitor the patients clinically. Okay. Now, what exactly does one do when you have to open up this abdomen in a type C and patient is deteriorating? So I'll just give you 4 or 5 principles what they do. See, once the abdomen is open, retractors are placed and exploration of abdomen is commenced. The pancreatic, biliary and the enteric suture lines are inspected. This is very important, all 3. Evacuation of pancreatic, next point. Evacuation of pancreatic ascites and fluid collection should be performed along with copious irrigation of the peritoneal cavity. As most of these reexpressions occur in the early posterior period, there's rarely intense adhesions, so don't worry about adhesions. Inspect all the anastomosis and evacuate the ascites. Now, great care should be taken not to disrupt the fragile hepaticojejunostomy or a gastrojejunostomy during exploration. Please note, they use the term fragile because it's early postoperative period. Normally, these are very good anastomosis, it doesn't leak. Okay, not as much as pancreatic jejunostomy. So don't try to disrupt and bother too much over there. Once the disruption of the pancreatic anastomosis is identified, the relative condition of the pancreatic tissues and the bowel is taken into consideration before determining the next step. Now, what to do next? Okay, most often there is a marked inflammatory response to a pancreatic leakage causing edema, hyperemia, and the friability of tissues. Obviously, the first 2-3 days after index operation. So for this region, don't try to do a simple suture repair of the leaking anastomosis, as this is doomed to failure and should almost be never considered. See, after a PJ leak, if you are in the small subset of patients we have to take into the OT, that is your best chance of saving the patient. Invariably, there's no second chance. Okay, so don't try and suture it at that time.
Sir, can you get back to the previous slide, sir, please? Next, that more previous, sir. Sir, thank you.
So I'll tell you shortly. First, what you have to do is that once you open up the abdomen, you do it in a controlled manner. First, you check for all the anastomosis, the enteric, the biliary, and the pancreatic. Then you have to evacuate all the collections that is there. You do a copious irrigation. Then what you have to do is that you have to make sure that you're not disrupting the HJ or the gastrojejunostomy. Okay. Then when you see if there is a pancreatic leak and you can identify or something, don't try to anastomosis immediately because it is going to leak again. So what of the options that we can do is that to convert the pancreatic into a pancreatogastrostomy. If the examiner asks you what to do, don't say that I'm going to repair it and come out. No. One of the options, you can say, sir, there's several options. One option is that to change the pancreaticojejunostomy into a pancreatogastrostomy, which sir has said how to do it. Now, in situations where the anastomosis appears largely intact, the patient is okay, and consideration can be given to establishing better evacuation irrigation of the pancreatic fluid with a larger closed suction drain or irrigating catheters. Okay. One may place a pedicled omentum or falciform flap over the visceral vessels. I think sir has said that to prevent pseudoaneurysm formation. Though the clinical evidence to support this base is anecdotal or observational data, sir has also mentioned that. So whenever you're really pushed by the examiner, then you say this, or else you do not say it. Okay. And whenever it's very controversial, just say that, sir, it's got very low evidence, so I did not mention it. Okay. Now, another possible approach to this is that deconstruct the pancreatic anastomosis and ligate the main pancreatic duct. As you said, when ligation has their own problems. See, neither wide drainage alone or ligation of the pancreatic duct is preferred due to unavoidable adverse consequences of the ongoing pancreatic leakage. For example, if you do a wide drainage, we can encounter a sepsis, electrolyte disturbance, loss of exocrine function, nutritional deficiency, ongoing major pancreatic fistula. If you do a pancreatic ligation, what happens? Acute pancreatitis can come, long-term pancreatic atrophy with complete loss of exocrine and endocrine function, almost face a brittle diabetes. So, however, there's some small subset in which the damage control is done, may be warranted to limit operative time with open abdomen and its attendant physiological consequences. I've seen just one patient in GEM where they have just opened the abdomen, come out, and then slowly it has healed. It required another operation though. There's one thing one term that some of you might know called Wursangostomy. I don't think sir has mentioned that. See, in Wursangostomy, duct of Wursang. From there it has come Wursangostomy. It's a variation of local drainage of the pancreatic bed that can avoid the undesirable consequence of a pancreatic duct ligation or completion pancreatectomy, that is Wursangostomy. See, after dismantling the dehiscent pancreatic anastomosis and the debridement of the distal pancreatic stump as necessary, a 6 to 10 French silastic tube with end and side holes is inserted in the main pancreatic duct and exteriorized from the right flank. Okay, you have dismantled the PJ, you put a small French, 6 French silastic catheter, and we have taken it out directly from the right flank. Obviously, you take a second operation. So, a pancreaticojejunostomy is then performed later once the fistula is controlled, infected fluid is drained, sepsis resolved, and the patient has recovered completely from the operation. Okay. Now, this might take almost 6 months. So, you have to tell the patient or your examiner in that way. So, this is usually done. Someone has a mic on.
I
Okay.
muted them, Rudrajit.
Thank you, sir. So, after 6 months, what are you going to do? So, this is usually done with a Roux-en-Y limb of jejunum to the fistular tract rather than directly to the pancreatic duct itself. So, you do a fistulojejunostomy after 3 to 6 months. Okay. Now, this is a bit higher level than used, but it's good for you to know this. Alternatively, is a variation of the versungostomy is a bridge stent. It's a similar silastic tube sutured in place to the jejunum, and pancreatic stump may be used to bridge the gap resulting from the pancreatic dehiscence. This technique diverts pancreatic fluid away from the peritoneum. See, the main problem is pancreatic fluid coming to the peritoneum, because then all the vessels are there, Anastomosis will occur, sepsis will occur. So, we have to divert it away from the peritoneum and preserve the pancreatic remnant, avoiding pancreatic endocrine and exocrine dysfunction or loss. So, then they'll ask, what is the definite operation? You say, sir, the most definite operation to correct a disruption of pancreatic anastomosis is a completion pancreatectomy. Do not answer this immediately. Whatever steps that I have told you first, say all those things and then you say these. This is usually performed in conjunction with splenectomy, so the spleen may be preserved. Completion splenectomy is required when the pancreatic remnant is found to be non-viable at the time of operation. When the pancreatic is already non-viable, which can be observed in rare cases of post-pancreatectomy pancreatitis. Okay, so do not go for completion pancreatectomy at first. Keep it in the back of your mind. Only say it as when you've already reached the honors marks, and just to impress the examiner one last time, you can say it. I'm not going to speak about nutrition because sir has said nutrition is very, very important. You have to continuously make sure that the patient is has got high protein so that he heals better. Okay, initially we do a TPN, and TPN is likely to be required until a postoperative ileus state has been resolved, vasopresses are weaned, and gut pervasion allows enteral alimentation. As soon as feasible, enteral nutrition, preferably a jejunostomy tube placed at the time of reoperation, or through a nasojejunal tube. The tube, the nutrition has to go all the way to the jejunum. Okay. Enzyme supplementation, they will ask you one question, which is very important. After completion pancreatectomy that you must do, and in a somatostatin, I'm not going to say, but the correct way to answer this is that somatostatin analogs may be helpful to decrease the volume of the drainage from recurrent persistent pancreatic fistula, though data are lacking in their efficacy in promoting completely healing and spontaneous closure. I think Sir has spoken of a somatostatin analog, which is in the works right now. Those you will know, I'm not going. So again, I'm stressing on the key points on how to avoid a complication. Is that patient selection is very important. Ductal mucous anastomosis, tension-free well-vascularized anastomosis, use of closed suction drains, and early removal of closed suction drain when appropriate. Please take a screenshot of this. I'll wait. Again, patient selection, ductal mucosa anastomosis, tension-free well-vascularized anastomosis, use of closed suction drains, and early removal of closed suction drains when appropriate. Okay. Key points of diagnosis and management is that, of course, start everything with the clinical parameter. As I said, tachycardia, tachypnea, as Sir has said, Sir has given 1 to 5 points, very important. Okay. Imaging, resuscitation, within these 3, it becomes very good. Sometimes you need an operation, and of course, the postoperative management of the operation. Now, what are the, again, last options for surgical management of major pancreatic anastomosis disruption? Are conversion of pancreatic to a pancreagastrostomy, wide local drainage with or without pancreatic duct ligation, versungostomy or bridge stent, or completion pancreatectomy. Okay. That's it. I think the storm is really strong right now. Anyone
Yes,
have any
Ramanu,
questions?
we've got some trees coming down all around already.
Okay, no, it's because my dad